Good evening, everyone. I'm Erica Smeaton. I'm the National Manager for Lymphoma Australia, and tonight we will be bringing you this webinar on COVID-19 and providing you a brief ATAGI update as well too. The need for this has obviously come about because there's quite a significant amount of questions that continually keep flooding all of our socials and all of our methods of communication with everyone as well. So the easiest way for us to reach everyone and provide clear and consistent information is through platforms like this. So the format for tonight, I'll provide a brief explanation regarding the increased risk of COVID to lymphoma patients. I'll provide a very brief explanation of what some of the data shows and provide some information about the ATAGI statement. And then I will also then move into what to do if you get COVID, and then we will end with a question and answer session with Dr. Josh Tobin. So COVID risks. So I think the most important thing for everyone to be aware of is that not one shoe fits all. So, and that's regardless of whether you have lymphoma or not as well too, because there is other external risk factors as well too. So people at increased risk include those in the older population, those who have an increased body mass index, people with a blood cancer or who have had blood cancer treatment, have had stem cell transplants, are immune compromised, or have other existing health conditions. So your considerations that affect your risk specific to blood cancer is your particular type of blood cancer and the treatment that you've had for that, how long since you were diagnosed, how your immune system is actually functioning at the moment, and also your fitness level as well too also plays a significant contributing factor. So understanding your risk. So lymphoma and CLL therapies are associated with a diminished immune system. So an immune response to the vaccine, which then also acts against the virus, is the key way to provide protection against COVID. Patients who have had treatment recently won't develop the same robust response that other healthy individuals do. We know that from international studies that some of the treatments that this is in relation to include agents such as rituximab, obinutuzumab, CLL drugs such as BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib, and BCL2 inhibitors such as venetoclax. So patients with lymphoma and CLL are more likely to be hospitalised as well too due to the severity of a COVID infection. So this little graph down the bottom explains basically that you're a high-risk patient if you have a B-cell lymphoid malignancy and you've had therapy as well too. So it also then goes into providing some guidance on what to do then as well too. So using exposure avoidance such as masks and social distancing, early intervention to prevent severe disease, so that encourages the need for testing if you develop any symptoms at all, minimising the exposure to long-term B-cell depleting agents. That's obviously not possible depending on your lymphoma as well too, but there's some instances where that may be possible as well too, but that's at the discretion of your haematologist. And then also the whole reason why we're here tonight is the third dose vaccine strategies that have been announced through ATAGI. So briefly, what does the data show so far? So there are several specific hematological diseases where the spike antibody serological conversion post-vaccination is lower. These include subtypes of NHL and CLL. So NHL and CLL patients have the lowest antibody response to the vaccine in the blood cancer community. So 40% of patients with CLL had a detectable antibody spike protein response after 2 doses of mRNA vaccine. So that's 4 out of 10 people with CLL responded when they had either Pfizer or Moderna. So Hodgkin's lymphoma patients appear to actually respond really well to the vaccine, with 99% of patients in studies becoming seropositive. So that's 64 out of 65 patients who were in this particular trial that I'm referring to actually did amount to good serological response. So as I alluded to before, treatment type actually has a profound impact upon your seroconversion as well too. So I've listed some of the common agents here that are used in non-Hodgkin's lymphoma treatment and also in the treatment of CLL that we know have an impact on your ability to seroconvert. So just over 4 in 10 people who have rituximab will mount an immune response. Half of the patient population who's on zanubrutinib will mount an immune response. just over 4 in 10 people who have acalabrutinib will also mount an immune response. And just under half of patients who are on ibrutinib will also mount an immune response as well to the vaccine. Unfortunately, CAR T-cell therapy, although not surprising, only 14% of patients who had CAR T-cell therapy mounted an immune response. It's a very small sample size, but it speaks to a larger percentage of people. So the time post-treatment also impacts the ability to be able to develop an immune response. So therefore, the further post-treatment you are, the greater your chance of developing an immune response to the vaccine. So in a small cohort of CLL patients, I think it was only 22 people, patients who were within 12 months of anti-CD20 therapy, so either Rituximab or obinutuzumab, didn't mount an immune response. However, patients who were at least 12 months post anti-CD20 therapy, 46% of them developed an immune response. So this speaks to the importance and the timing of your third dose as well too. So what we do without a doubt know is that vaccines work. So this graph shows the results of people who received an mRNA vaccine, so they're the Pfizer or Moderna. It clearly demonstrates the incidence of COVID infection was significantly lower among vaccine recipients when compared to people who received the placebo. So the purple line at the top was people who received the placebo, and the orange line down the bottom was people who received the vaccine. So, interpreting the ATAGI statement. So, the majority of patients within the LA community will be eligible for a third dose of vaccine. So, anyone with an active hematological malignancy, anyone on treatment, or anyone on watch and wait. The statement active malignancy covers all of those people. I think it's important as well to highlight the timing of your vaccine. So timing your third vaccine should be between 2 to 6 months post your last vaccine dose. So rushing out to get the booster, although in that time frame may not necessarily give you the best chance of developing an antibody response based on your individual circumstances. So with this in mind, the timing of your booster should be discussed with your treating hematologist, as this decision will be guided by a number of factors. So these factors are things like, but obviously not limited to, but are you on active treatment, or how recently have you completed treatment? Your age and your comorbidities, your imminent risk of COVID. So unfortunately at the moment, imminent risk of COVID is fairly state-based as well too. People in the southern states are much more likely to be exposed to COVID than people in Queensland and WA. Other important factors are what subtype of lymphoma you have and what treatment you have had for that. So for some patients, the best chance of actually developing antibody response may be to pause their maintenance treatment or their BTK inhibitors, but this needs to be done under the guidance of your hematologist, not independently. And the risks of these decisions will need to be carefully considered based on your individual circumstances as well too. It's not one shoe fits all. Sometimes the risk of stopping your BTK inhibitor is greater than the risk of COVID as well too. So that's something to keep in mind as well going forwards. But as I said, that needs to be discussed with your hematologist. So stem cell and CAR T-cell patients within 2 years of treatment should be carefully within 2 years of treatment should be fully revaccinated 3 to 6 months post completion of transplant, regardless of vaccine status prior or during transplant. So that means 3 doses again. All patients more than 2 years post-treatment will need to discuss their individual risk with their treating hematologist as well too, because it's not one shoe fits all. Your immune system may be functioning fairly well 2 years post-treatment, but again, that will be determined by your individual status, what treatment you've had and what disease you had as well too. So the best person to determine your need to have a third dose and the best timing is your hematologist. How to access the third vaccine. So what vaccines are currently available for third dosing? So all states will have access to Pfizer and Moderna. Unfortunately, they're not all available. Both vaccines aren't necessarily readily available just yet, but they should be fairly soon as well too. So it is a state-based rollout system. And the health system is currently trying to catch up with the ATAGI announcement. So it is also going to differ slightly from state to state as well too. So the general advice with that in mind is that people should be able to get their third dose either through their GP without needing a specialist letter if your GP is up to date with what your current situation is. However, if you're attending a state-run vaccination clinic, patients are more than likely to require some type of letter from their specialist, at least in the short term until all of the kinks in the system are worked out. But some alternatives to letters as well too, as I recognise that people may not necessarily be seeing their haematologist very often. So alternative options to providing documentation include things like a hospital discharge summary as well too, a treatment record, a copy of a chronic disease management plan, and this was also mentioned as well too, but I think it probably needs to be used with caution, but a script in your name for a medication that's indicated in the use of the relevant medical condition. But I think that out of the options there, I think that's probably the most likely to cause some concerns with accessing the vaccine, the third dose. So what should lymphoma and CLL patients do to ensure their ongoing safety? So 3 vaccines doesn't ensure full protection against COVID for the immunocompromised patients. You may still have a lower immune response than a healthy individual, but regardless of your vaccine status, it's really important to still continue to practice risk mitigation. So socially distance, wear masks, wash your hands, encourage family and close contacts to get vaccinated and get tested if unwell. So I have kept it very brief with the update as well too, but I wanted to give everyone the opportunity to ask questions as well too. So as we move into this section of the webinar, I'm sure we'll get lots of very specific and personalised questions, and we'll try our best to answer as many questions as possible, but we won't be able to answer questions based on your individual clinical situations, and would encourage you to discuss any information from tonight's event with your treating haematologist. So to do the question and answer section with me, I will welcome Dr. Josh Tobin, who is a clinician scientist at the Royal Brisbane Hospital Haematology Unit and at the University of Queensland. He has recently been awarded the prestigious Snowdome Haematology Fellowship and the American Society of Haematology Global Scholar Award. Dr. Tobin's research focuses on the interplay between the immune system and the development of indolent lymphoma. Ultimately, the goal of this work is the development of clinical tools which can be used to select patients for biologically rational trials of immunotherapy in order to improve patient survival and limit the toxicity from conventional chemotherapy-containing therapies. So welcome, Josh. I'll just unmute you.
Hey, Erica.
Hey, Josh, come on in.
Can you see me at all?
We can't just yet. There we go.
Hi, Erica. Thanks very much for having me.
Thanks for coming, and thanks for
pleasure.
offering to do this as well too. We very much appreciate it.
No, it's a pleasure, and look, just to say, it's a really privilege to be able to speak to directly to everyone tonight. I think as a clinician, a lot of our clinics are really overburdened, and every patient, at least 2 or 3 a clinic, really want to sit down and talk about these vaccines, and that's only sort of increasing in frequency now that the third dose has been announced, and it's people are very uncertain about what that means for them. I guess my goal for tonight is not to be able to give everyone a specific piece of advice that they can take to their haematologist and said that some bloke in Brisbane has said that they should have this, but rather try and answer some of these big burning questions, give you guys as much information as we can. And so you can then go sit down with your haematologist who knows your case well, your disease well, and your specific risk of the disease in your home state, and make a decision about what's going to be best for you moving forward. So it's great to be here. And I think maybe before we start, I can see there's heaps and heaps of questions going up.
Yes.
I might just take a quick second to touch on the ATAGI guidelines, because they are a pretty dense document, and Erica, thank you for doing so much background reading and summarizing that for us. I might just touch on probably what I think are the 3 biggest pieces to come out of that recommendation from ATAGI, which is our that's our immunology society that really gives guidance to clinicians about how to vaccinate patients in complicated situations and if they've been invaluable in COVID. So the first new recommendation that's come out of ATAGI is that for people who are quote unquote severely immunocompromised, that they recommend a third dose of the COVID-19 vaccine. And this is following in a trend globally where people are starting to recommend a third dose more generally. I think healthcare workers are not far behind. In the US, they're starting to recommend booster shots more broadly for the general population. The Australian recommendation right now is that that's just for severely immunocompromised individuals, quote unquote. And they've outlined quite specifically what that means for the Australian population. And importantly for everyone, I think most people that are here tonight, they've included one of them, actually the first indication is people with active hematological malignancy. So active hematological malignancy is not really strictly defined. They've left it fairly open to interpretation, I think. My personal interpretation, I think the interpretation of most hematologists would be anyone who has the presence of a disease that we can't cure, a hematological malignancy. So your indolent lymphomas, myelomas, people who have ongoing measurable disease that can be cured, and people who have experienced significant immunosuppression from their treatment. So that's people who have had something like a stem cell transplant or CAR T therapy in the recent past, and that typically is considered to be 2 years, and this guideline actually specifies 2 years from a stem cell transplant. To touch on the rationale for why they've made that recommendation, it's very clear from data globally that immunosuppressed patients have a longer SARS infection. That's problematic not just for our patients, but also people who have longer SARS-CoV-2 infections have higher rates of evolving variants. So globally, for our communities, that's a problem. They also have higher rates of being hospitalized, higher rates of going to ICU, and higher mortality rates when they're infected. And so there's a need to provide these people with better protection. The second reason for pushing for a third dose in this cohort, particularly the seroconversion rate, so the ability to make an antibody after getting the vaccine, is lower in patients with hematological malignancy or immunosuppression than they are in the general community. And we can talk a little bit more about what serological conversion means later on if anyone's interested. But I think the fact that we have a group of patients that we know are at risk and a group of patients that we know don't respond as well to the vaccine means that we need to be doing more for them. And that's where this research and subsequently the recommendations come from. So that's the first big take home that I think everyone should know from tonight would be for people with any active hematological malignancy, that they would be recommended to get a third dose of COVID-19 vaccine. The second big recommendation to come out of it is when to get that vaccine, which is a really vexed question because everyone's will be a little bit different. The broad strokes they've said would be that it really should be between 2 and 6 months after the second vaccine. So you get your first 2 doses as per the normal schedule, and then get your third one in that sort of 2 to 6 month window. If you've already been more than 6 months, which many people I suppose will be now, then the recommendation would be to do that whenever it's available, so as close to that 6 month period as you can. And for patients who are on ongoing treatment, the recommendation is to have that vaccine at least 2 weeks before commencing a new treatment. And that's really the dicey one. I guess we need to be very careful about compromising our care of what we know are important diseases like lymphoma and leukemia for the sake of fitting this 2 week arbitrary window in. So that would be my second take home for the night, would be when to get the dose 2 to 6 months after your second. In absolutely critical circumstances, that could be moved forward for a month. And if you've been longer than the 6 month window, then the recommendation is to get it when you can. And I think the third big piece of advice from out of this document was what vaccine to get. So the recommendations in this guide are actually pretty specific, which is not common for a guideline of this nature. So, and they have actually recommended that the third dose, regardless of what your first 2 doses were, be an mRNA vaccine. So in Australia, that's Pfizer at the moment, Moderna soon. That rationale for that is not necessarily that overall the AstraZeneca vaccine is worse. It's more that on the first dose, we've seen that the AstraZeneca vaccine seroconverts less people than the first dose of the Moderna and Pfizer vaccine. By the second dose, that's all caught up. The feeling being that if we're only giving one additional dose, it should probably be the one that seroconverts the most people. If that means that you're crossing your vaccines, like you're an AstraZeneca first, and now you're getting your Pfizer, that's okay. And actually, in non-immunosuppressed people, there's some suggestion that might be better. Similarly, if you're just getting if you've already had the Moderna and Pfizer, there wouldn't be a recommendation that you go try and cross over to the AstraZeneca. They still do think you should continue to get that third dose of the mRNA vaccine. So those would be my three take homes. Would be anyone who's got a hematological malignancy, get a vaccine, get it between 2 and 6 months, and that vaccine should be an mRNA vaccine. So I can see just question after question popping up. Yes. I might let Erica curate all the questions, and I will just do my very best to try and keep up. I should just preface everything by saying that whilst I'm very interested in immunology in cancers, and that's what my research has all been in, Erica and I both live in Brisbane and have worked in Queensland, and we've had very, very few cases. The vaccination strategies have all been really prominent, and we're both at Gold Coast Hospital when we were rolling out the initial wave where Gold Coast was quite front facing with a lot of our interventions. So I'll have to apologise that if there are any specific questions about COVID, the disease, and how to manage it, that's probably not going to be my strength, but I'll do my very best.
And that's all right. We can always have a follow-up as well too. This doesn't have to be the only opportunity for questions and answers as well too. So there's plenty of other experts as well too that we can tap into if this is not quite your area. So if you've got questions, please still ask them, because we will be capturing all of them and can take them elsewhere as well if we don't know the answers. So Josh, first question. So this is one that we constantly get asked as well too. Patients currently undergoing treatment, should they get it now or wait until after they're finished treatment? Yeah,
that's really the money question. I think probably 2/3 of the people that ask me about this in the clinic, that's really that they want to get to the bottom of. I'm not going to give anyone a satisfying answer tonight. I think this is something that we ultimately have to say is incredibly patient dependent. And it really is a discussion for you to have with your hematologist, acknowledging that not everyone's an expert in COVID vaccines. To give an example of how patient dependent it is, I guess maybe just to give you two examples. I have a patient under me at the moment who's an ALL patient. So ALL is a very aggressive form of leukemia. He's now not even 6 months into a course of high intensity chemotherapy that will last ultimately probably 2.5 years, and may turn into an allograft. There's a few elements to that are important to know. So ALL has actually got very good seroconversion rates compared to a lot of lymphomas. ALL probably about 90%, which is close to the normal population. And he's so far away from finishing treatment that it wouldn't be reasonable. In Queensland, we're expecting to have a wave soon, or in other states where a wave, COVID's already very much taken hold, to wait for 2 years to try and give this guy a vaccine. And so for him, the recommendation is then we'll try and find a window where you kind of have two-ish weeks between therapies, and we'll just go for it. By contrast, we've got another lady who's older and is a lot more concerned about COVID, but she's actually in her last 3 months of a venetoclax regimen. Venetoclax is a biological agent that we stop after 24 months, and she's currently in a remission. And we know that in CLL, patients who are off therapy and in a remission get better response rates than people who are on therapy. Given that she's got 3 months, the decision was made to defer. So, look, it's an incredibly complicated question. I think trying to lump, that everyone that's in this group into a single answer would be very, very hard. And for that reason, I think you're going to have to take your individual case to your hematologist and ask them what they think is best for you, I'm afraid.
Yeah, it's not one shoe fits all, is it?
No.
So watch and wait patients as well too. This is another common question that's very similar as well too. Do they currently qualify, and is it recommended that they have a third dose before actually needing treatment?
Yeah, so this is an area of real interest for me, is how the immune system functions in patients who have got watch and wait disease or treatment naive disease. So, there's a large cohort of patients, particularly those with indolent lymphomas or CLL, who have been diagnosed with disease, but it hasn't reached any critical thresholds where treatment needs to start. And for those patients, we will just observe them and in a sizable proportion, and they will never go on to get treatment. So the first thing I'd say is that, yes, those people are all classified as having a quote unquote active hematological malignancy. And so they are entitled to, under these recommendations, a third vaccine, and it would be recommended. And the reason for that recommendation is that even though they're not, patients that are being watched aren't on a therapy that suppresses their immune system, like a chemotherapy or rituximab or the like, we know that broadly the immune system is dysfunctional. We know that broadly patients will make less antibodies than a healthy comparison group. And from smallish but pretty meaningful and convincing studies, that patients with watch and wait disease have lower seroconversion rates, so lower abilities to make an antibody specific to COVID from the vaccine than a general population. And that tells us that the disease is actually impairing the immune system, not just the treatment. To answer the question directly, yes, watch and wait patients are very much qualified for that vaccine, and that we would strongly recommend that they do have it, in line with the recommendations for everyone else.
Yeah. I think that will probably answer quite a few questions that are coming through as well too. Can you also explain antibody testing? It's a very hot topic, and whether or not patients should actually get antibody testing.
Yeah. I'd be very interested to see, I know there are some sites that offer it, and I'd be very interested to see what kind of information patients are getting back. What I can tell you is that the current recommendations and best standard care is that we don't do the antibody testing. The reason for that is a fewfold. I guess the first thing is that we don't have any studies that show necessarily that the antibody testing is the same as effectiveness of the vaccine. There are other elements to how vaccines work that need to be measured and currently aren't. The serology, which is what that's what antibody testing is a very easy test. It's something that we as clinicians use all the time to look for things like CMV and EBV and hepatitis, but it's not a perfect test by any means. That makes things difficult. The other thing is that currently in Australia, as far as I'm aware, there is no standardized protocol and no way to interpret antibody testing. So where each individual lab draws a line and says this person is positive, this person negative is not standardized. That process takes big consortiums of trialists to get together and come up with a standard. And until that's done, interpreting antibody tests is incredibly hard. And the recommendation at the moment is that it shouldn't change anything that we do. So, if you're a patient that fits the criteria for that third vaccine, regardless of whether you've had an antibody test that shows that you seroconverted, the recommendation would be that you have it anymore, either because it could deepen your response, it can make your antibody titers higher, or because the test might be wrong, and we don't have a good way to tell.
No, fair enough. And I think I think that is probably the most commonly asked question as well too. So yes, I think that's a very good point. Another thing as well too, how long post chemo immunotherapy are people less likely to have a robust response? It's a very broad sweeping statement, and it's going to be pretty tricky to answer.
I won't be able to give a perfect answer to this. I guess part of what's so hard about the way studies are published at the moment is it's such a new disease, and the vaccines are coming out so quickly that we kind of lump all of our hematological cancers together. And obviously they're really different. They get treated with entirely different drugs. Some of them are chemo, some of them are biologics that only affect a certain limb of the immune system. So the data that we pull out is equally messy. and very, very hard to interpret. For me, the best evidence, and probably the one that should be most relevant to, I would think, most of the patients here, assuming this is a largely lymphoma-based cohort of people, is the data on rituximab. And that's something that has been studied in other vaccines a lot, and was an area of interest, I think, when a new vaccine was developed. So I think Erica touched in her very comprehensive summary at the start that patients who have had rituximab or a similar antibody in the last 12 months don't seroconvert as well as patients who have had more than 12 months off. It's possible that that's also true of 2 years, patients that get seroconvert more after 2 years. In terms of what that means for you, like when it's best, I think it's best, and this is my personal opinion, to get the vaccine as soon as you can within reason, if you fit into that guideline. I think we shouldn't be looking to stop therapy, would be, I think, a pretty commonly held recommendation amongst hematologists, although that is done occasionally. And I think we should just try and get as many people vaccinated as well as we can as soon as possible. And if that means that you're getting a slightly less efficacious vaccine at 6 months rather than 12 months, that you've had 6 months more protection, that would be my recommendation. And that's something that's being monitored very, very closely in studies going forward. And hopefully by the time we're getting our next booster, and I do expect we probably will get rolling boosters, we'll have better answers about when to do that.
Another question that comes through as well too, and particularly for those who have had AstraZeneca as well too, is which vaccine should be the third vaccine?
Yeah, so I touched on that briefly, but I think it is just worth reiterating because people do really care about what vaccine they get, and in many respects, I think a lot of patients are maybe more informed about the specifics of each vaccine than a lot of healthcare workers are. The recommendation from ATAGI is that everyone should get an mRNA vaccine for your third dose. And again, that's not because there's necessarily a better or worse vaccine. It's because the response is quicker to the mRNA vaccine. So if you're only going to get a single top up, that would be the recommendation. If you're crossing over from the AstraZeneca, that's somewhere between the same and better. And if you had Pfizer to begin with, then we would not recommend that you go get the AstraZeneca vaccine to intentionally cross over. There's no evidence to suggest that that's a good or safe thing to do, and probably is less helpful.
So there's lots of questions as well too coming through about antiviral drugs as well too, and I know that there's been a few that have been approved by the TGA as well too. So one of them, Margaret's asking about as well too. So Trovimab, do you want to comment on that?
I truthfully don't. Other than to say they're not drugs that I use, and they're probably not drugs I expect many hematologists to be using regularly at any point. I think the way most hospitals are being set up to manage COVID outbreaks will be that if they have COVID, they'll be managed by a specialist COVID team. That team is often multidisciplinary and often will involve an intensivist and a respiratory doctor, plus or minus the specialist teams who will come by and offer their disease-specific advice. As a broader point, I think philosophically there's something important with knowing about these, which is to say for most of the population that don't have an issue with mounting an immune response with the vaccine, the first line and probably the best line of defense against COVID will be getting vaccinated. And that's true on a community level as well. If the vast majority of the community is vaccinated, then overall we are better protected. For patients who can't necessarily mount those vaccine responses, there's really 3 things that we can do to help ensure they stay safe. The first is all the things that we have been doing for the last 12 months, and I think particularly hematology patients have been excellent at, and probably have all been excellent at well before the pandemic, which is making sure that you're conscious of your hand hygiene, mask wearing, social distancing, and frankly, I mean, the rates of other respiratory infections have also dropped dramatically, at least amongst patients that we have here, and also me personally. Like I used to get sick every 3 months, and now I haven't had COVID. The second thing is make sure you have a bubble of immunity around you. It sounds kind of preachy and like a sales pitch, but if you can't get vaccinated, having everyone around you being a wall against the disease is very valuable. And the third thing, which is important, is that we do have treatments now for COVID that in Australia we're starting to be able to access. So I don't know, I probably would be beyond myself to speak about the specifics of Regeneron or the recombinant antibodies. I certainly probably be out of my depth if I was talking specifically about how we would manage a COVID positive leukemic patient or lymphoma patient. But other than to say that we have got drugs that we can use for patients who are seronegative or presumed seronegative on diagnosis, and for patients who are have more serious disease, and hematology patients will always be considered to have more serious disease. So if any indication says this is only for patients who are likely to progress, which is what most TGA emergency approvals are, hematology patients will always be considered likely to progress, because we know that they're a more vulnerable people.
Yeah, and I suppose getting access to these drugs as well too is firstly important to know that you actually have these drugs and that there is options as well too. And I think accessing these drugs is important, particularly when you're talking about treating infections early. So I think the key to drugs like sotrovimab is getting to it in a very timely manner as well too. So I suppose it just emphasises even more testing at the first sign of symptoms as well. So just drive that one home.
Yeah, and look, again, hematology patients have always been so conscientious about getting a fever, you come to hospital, you get respiratory symptoms, you come get a test.
Yeah.
I think all the things that we've always built set us up really well to keep people safe, and the COVID precautions are really just an extension of that for patients who don't have optimal vaccination responses.
Yeah. So something that also comes through regularly as well too is we've already answered this as well too to a certain degree, but does lymphoma itself actually make the vaccine against COVID less effective than other types of cancers? So I guess we haven't said that in as many words. No.
There's a reason that that the ATAGI guidelines specified hematological cancers. If you take just really broad strokes, and please don't apply this to your own personal lymphoma or leukemia, that patients with solid tumors tend to see sort of 80% antibody responses to the vaccine, and hematology cancers writ large tend to see closer to 50% if you take everyone together. Probably maybe reassuringly, I should mention that there are some hematological diseases that don't seem to do quite so badly to the vaccine. So Hodgkin's lymphoma, for whatever reason, they in the relatively small but pretty meaningful studies we've done on cohorts of Hodgkin's patients actually have excellent response rates, like similar to the general population, of about 95 to 98%. Myelomas do pretty well. ALL, we touched on earlier, has pretty good response rates as well, or upwards of 90% response rates. So if you're in one of those categories, that's excellent. You still qualify for the third dose, and I would still recommend you get it in case you are one of those 10% that doesn't respond, or if you've got a lowish response, which is not something that we have a good read on, whether higher antibody responses are better. Conversely, it's probably worth saying that there are some diseases that have much lower rates. Indolent lymphomas, follicular lymphomas, marginal zone lymphomas, which are probably my area of interest, they seem to have probably the lowest response rates. They're in the 30%. That's all comers, treatment, non-treatment, and CLL and aggressive lymphomas probably sit close to 50% taken all comers. So it does vary quite a lot, but certainly hematological cancers are at a higher risk of not responding to the vaccine than solid tumor cancers, and that's why it's a pretty broad recommendation to all of our patients to please get that third vaccine when it's available to you.
Okay, so more questions on vaccine mixing as well too. So is it best to mix? So if you had, for example, 2 Pfizers, do you get a Moderna as the third? Or do you try and stick to Pfizer?
It's a good question. I don't believe that there's been a meaningful study on whether the crossover applies to a third dose. and whether the crossover applies to those two specific vaccines. I wouldn't want to offer a suggestion, because I don't think there is a consensus, and if there's people that I think propose that there is, I think the data is too scant to suggest really strongly one way or the other. You're probably arguing in the margins if that's what you're getting hung up on. You know, you're probably talking about a couple % either way, whereas what's actually matters is just getting that vaccine when you can, rather than putting it off to get the Moderna, putting it off to get the Pfizer, whatever it is. My personal belief is that that's what's more important. But yeah, we'll watch this space. It may very well come out that we mix vaccines in the future.
Yeah. More questions that are coming through as well too. Lots of questions coming in. So if you've got questions, just keep popping them in as well too. I'm trying to make them as specific as possible as well too. Wendy's just commented and said, so she's been in contact with the director of the New South Wales COVID vaccination clinic regarding Pfizer and pericarditis questions as well too, because I did see that someone was asking that before. And he said in recent discussions with cardiologists that they're suggesting still going ahead with Moderna unless severe pericarditis. But again, this would be best discussed with your doctor as well too, because it's going to be dependent upon your situation.
Yeah, I would just add, that's a great point. I mean, I personally haven't seen any pericarditis cases that have been directly attributed to it. It's a pretty rare event, but we're always on the lookout for it. The ATAGI recommendations did mention it, and they did sort of suggest that if you are contraindicated to getting the mRNA vaccine, that you should probably get the AstraZeneca. I personally don't know that anyone can say hand on heart what the right thing to do is. If you had the Pfizer myocarditis, should you get the Moderna? I actually probably would say that the AstraZeneca might be a better option for that very, very small group of people. Similarly, people who had anaphylaxis to the mRNA vaccine, which is probably more common. Again, I would not chance fate and try another similar vaccine. I would recommend the AstraZeneca, and that's what the ATAGI had recommended, but they've left that a bit vague. Because I don't think we have a good handle on what causes that pericarditis and whether it's a class specific problem, whether it's every mRNA vaccine or whether it's just a Pfizer specific problem where it seems to have got at least the most media attention, the most traction.
Okay, and there's a question, we touched on boosters as well too, because I suppose to clarify, this is a third shot as well too. So it's not a booster, but will we still require a booster going forwards even after we've had 3 shots? Is there much evidence about that just yet?
It's something that the data for general populations is only just reaching. Like, what is the true benefit of a booster? It seems to be fairly helpful. Certainly in the emergence of important variants like Delta. I don't want to try and see the future too much. I suspect that the 3 doses that you have as a hematological emergency patient will just be considered your vaccination, your first vaccine, and that boosters will be rolled out on an annual basis with everyone else. So in the same way in the same way that we get a flu vax every year it'll be COVID season, we'll get a COVID vaccine. Or every couple of years, I don't know what the schedules will be, but I wouldn't think that this would mean you get away with not getting your booster shot when it comes around. Sorry.
No. There's another question that's come through as well too, questioning about Novavax as well too. It's not currently available, but any comment on the Novavax?
I've got a lot of people ask about Novavax. Look, it's the least studied. It's obviously not something I could have possibly had any experience with because we don't have it in Australia.
No.
I understand hesitancy about the vaccines we've got, but I don't think there's any evidence to suggest there's a better answer. I also think as we start to see New South Wales and Victoria, who have been really, really ravaged by outbreaks and now established disease in the community, it's very clear that those small, really marginal concerns that we all have rationally really fade out in the face of a really dangerous disease. So I don't know. I certainly wouldn't recommend to any of my patients that we hold out for another vaccine.
No.
Certainly over time, vaccines will be improved. This is very much a technology in its infancy. And we are monitoring very closely for signals that suggest something is better than anything else. But there's always going to be another vaccine around the corner. There's always going to be a suggestion that it could be better. I think we should go for now with the vaccines that we have and know that we have shown in big trials, like our empiric best way to measure this, are safe and pretty effective. So yeah, I wouldn't wait for the Novavax as a general comment.
No, and I think that things will continue to change as well too. Everything with this is a bit of a fluid situation as well too, as more and more information comes to hand and more trials are done in this area. There's a question, how long after chemo and achieving a remission are you actually regarded as having an active hematological malignancy?
Yeah, no, great question. Intentionally vague. What I would say is that people who have indolent disease, that question doesn't really apply. So I know that it can be confusing to tell, when doctors talk about you, whether you've got an indolent disease or a disease that's cured and gone further sometimes. So your CLLs, your follicular lymphomas, marginal zone lymphomas, mantle cell lymphoma, those diseases, even though they can be put into enormous remissions that can go for your entire life, that the assumption is always that we don't cure them, with the exception of some very, very rare circumstances. So for those people, you've always got an active hematological malignancy, even if it's in a perfect remission, has been for a long time. So patients who have curable diseases, aggressive lymphomas are the biggest one, lymphoblastic cutaneous. If you receive high intensity chemotherapy to the point that it's a CAR T cell, an autologous stem cell transplant, or a allogeneic stem cell transplant, you would be eligible actually not just for the third dose, but actually to get all of your vaccines again. And that's not just for COVID, that's for everything. If you have a stem cell transplant at 3 months, 3 to 6 months, we start your childhood vaccination schedule again. And that will now include your COVID vaccines with your third dose. I know it's confusing. I hope that's clear. For everyone else, the guys that are too aggressive to be considered indolent, but not so much that they got stem cell transplants, I don't have an answer. I think that will be at your clinician's discretion. And I think the guidelines were intentionally non-prescriptive about that. Generally speaking, I wouldn't get the vaccine after something like R-CHOP, like standard intensity chemotherapy, for a few months. I don't know that there's a perfect time, but definitely let the chemo cycle finish, get restaged, and then consider it. Don't rush out and get it in your last cycle. But yeah, I think for that relatively big cohort of people, we won't have an answer, and active hematological malignancy can mean what you want it to mean.
I think that's very true, and like you said, intentionally vague. That's the take home. I'm actually going to start a quick little poll as well too, because we're interested to see how many people since the ATAGI statement have actually already had their third dose. So this will pop up on your screen shortly. So I'll just wait for a couple of responses as well too. So how many people have had their third dose already? Oh, it's very interesting to see some of these results come through. I'll share them all very, very soon. Oh, coming in thick and fast. Okay. So unsurprisingly, the vast majority haven't yet, but there's still a few, about 15% of people who have actually had their third dose already. So yeah, I think that's very interesting actually too. There's about 20% of people who are unable to just yet. Oh, and someone's just commented and said that they had it today. Good on you, Margaret.
Congratulations to that 11%. That's awesome. I think you'll find most clinicians aren't really aware of how to do it yet. I mean, it's very impressive if you managed to wrangle your hematologist to get you a letter already.
Yeah. And I think the system's still got to catch up as well too. There is going to be a little bit of a time delay as well, because I think this has all happened very, very quickly. Oh, here we go. More people are commenting saying that they're still, they're having this. So that's excellent. So I'll just pop the results up on everyone's screen so you can see. They should have popped up there too, but I'll just see if anyone else has got any questions as well too, just pop them through. But just wait and see if some more.
I might just comment on that then. I guess from a practical point of view, for those of you that haven't, how do you go about getting your third shot? I mean, you know, most people will be eligible. It's going to be something that takes a little bit of time to figure out exactly what the best way is, and each institute will be different. I'll tell you a few things I do know about how they're rolling out nationally. So testing centres have been informed right from the announcement of this guideline, vaccination centres from the outset, that this is something that they should be expecting an influx of. So the expectation should be that if you get a letter from your haematologist specialist, and it does have to be from a specialist, saying that you're part of this immunosuppressed group that qualifies as per the ATAGI guidelines, that they'll just give you the shot. There shouldn't be any further debate around it. Certainly no need to show antibodies or show history of your cancer or anything. For more recently, and this has been maybe less organised or at least more staggered, it's been rolling out to GPs and pharmacies, but as in, you know, with any sort of development in medicine, it does take a little bit of time for everyone to take it up. So there may be GPs that you've got these letters to who just don't know what you're talking about. And I would very strongly advise you to point them in the direction of the ATAGI guidelines and say that's what this letter is about. And I have no doubt that any haematologist that has gone to the effort of writing that letter would happily take a call from the centre that's denying heat of vaccination and just correct them. So it is tricky. I can tell you that at our hospital, the other thing is that it's really hard to see a specialist soon. It's hard to just call up and say, I want an appointment. So we've actually got a clinical nurse who's fielding those calls that want the letter. The letters get printed off every morning. The consultant that knows the patient signs them if it's appropriate, and then they just get sent out. So you don't need an appointment per se, and that's been really streamlined. If that's not something that currently exists at your centre, maybe speak to your clinical nurses or and I'm sure the Lymphoma Australia nurses have plenty of connections with every one of the hospitals that you guys would be at.
And I think that most of the hospitals are already taking preemptive steps as well too. And it like you said, Josh, it may just be a call to the hospital itself and to speak to one of the nurses as well, who will probably already have a process in place as well too for this.
As a broad comment about haematology units, the clinical nurses or lymphoma nurses almost always have a plan before the medical staff have figured it out. And that would be my point of call.
Yeah. Okay. There's a question. Gosh, there's so many more still coming through. There's many comments on everyone in Melbourne as well too.
Because Melbourne's out of lockdown tonight.
From tonight. This is actually quite timely.
Yeah.
I would say that, people have said pharmacists had Moderna and booked easily online in Melbourne. So definitely felt a certain sense of urgency given what's happened as well too. I think that's probably echoed in quite a few people as well, Margaret. What else? I don't think there's any other real questions that are coming through at the moment as well. So if anyone who has missed part of the talk as well too, because some people are signing in late as well, it will actually be available afterwards quite quickly. So someone specifically asked about Perth as well too, and asked if you can get a booster in Perth, and you can have your third dose in Perth. It's across the country, even though Perth doesn't have the same degree of cases as down south. Third doses are still available across the country, so it's not specific to where you are. Do you have anything to add to that, Josh?
I think that's similar in Queensland where we work, I guess. Until you start seeing cases, the impetus to get really well vaccinated is not quite there, and that filters through the medical staff not knowing the super up-to-date guidelines. So if you're in Queensland, South Australia, Northern Territory, WA, where the cases have not been so extraordinary, you may need to poke and prod your GPs to understand the data. But I have no doubt that they will very rapidly take that advice on and get you guys vaccinated.
Yeah, and there was someone who asked how to spell ATAGI guidelines as well too. So I think we keep blazing past it, but so you can print it out or notify your GP. It's actually ATAGI. And even if you've just Googled it at the moment, it's the first thing that pops up because I think it's the most commonly Googled thing at the moment when it comes to ATAGI. So I don't think there's any further questions at the moment. So I will pop a quick survey up on the screen as well too. So if everyone can take a minute to fill out their survey, so you can either scan the QR code or click the Survey Monkey link just to fill out the survey. We are looking at having another session as well too, because like I said, this is a very fluid situation. So I'm sure the need will be ongoing for more information as well too, and to clarify further information. Fill out the survey for us, but then I think if that's not all questions, I think that then we'll say good night to everyone and stay safe, particularly as borders open. And thank you very much to Josh for taking the time to do all of this as well too.
Absolute pleasure. Did I drink a lot of Coca-Cola? Someone's saying I should be hitting them up for funding. I'll keep it in mind.
Sponsorship.
Yeah, no, absolute pleasure. Thanks very much for having me, Erica, and everyone.
Thank you.